Hello everybody. Over the next few minutes we will talk about how to bring quality to the MRI diagnostic pathway. Here are my disclosures. So over the next 10 minutes we will recall the benefits of the prostate MRI pathway emanating from true findings, true positives and true negatives. We will highlight the sources of variability affecting positive and negative predictive values, and then I will suggest strategies to quality control this process so that we can get a more consistent delivery of the pathway benefits. There are four major benefits of the prostate MRI pathway. The biggest benefit is a reduction of the number of patients undergoing a biopsy, and thereafter a reduction in the diagnosis of indolent cancers, and this speaks to the rule-out ability of prostate MRI or its negative predictive value. But in some patients we know that we more accurately diagnose tumor grade and tumor volume, and for previous negative biopsy men we increase the diagnosis of clinically significant cancers, and this speaks to the rule-in ability of MRI or its positive predictive value. Now all of us have seen graphs like this. You can see that the greater the PI-RADS score, the greater is the prevalence of clinically significant disease, not only grade group 2 and above but also grade group 3 and above, which is why the PI-RADS categories are not only diagnostic but they are also potentially prognostic. But there's another way of looking at this data. So if you took a positive MRI to be PI-RADS 3, 4 and 5, you can see that for PI-RADS 3, the false positive rate is almost 90%. For PI-RADS 5, you can see the false positive rate is almost 30%. And false positives and false negatives affect patients in different ways. So on the right-hand side, you can see that if you have a true positive, you diagnose clinically significant cancers and patients are treated with risk-appropriate therapies. On the other hand, if you have a false positive, what that means for patients is that they are exposed to biopsies, biopsy risks, the chance of being diagnosed with an indolent cancers, and being on active surveillance for years and years and years with all the procedures and costs that go along with that. Previously I said that the biggest benefit for prostate MRI was its high negative predictive value, in other words true negatives, and that helps to reduce biopsies and reduces overdiagnosis of cancers, which is why that is the benefit that is often emphasized. So how much variability is there in the positive and in the negative predictive value of MRI? It turns out that the negative predictive value is very high and the variability is very little. The positive predictive value is quite inconstant between centers and there is a very high variability. So here is data from 8 of 10 UK centers that biopsied men who had a negative MRI. And you can see that the negative predictive value was 88%, but importantly there was very little variability between the centers. Now the positive predictive value is quite inconstant with high variability. So this is 26 mostly US centers. And look at the variability in the positive predictive value between the centers for when they did targeted biopsies of PI-RADS 4 and 5 lesions. You can see that it varies from about 26% to about 75% and averages out at about 48%. So a lot of variability on the positive predictive value side, much less variability on the negative predictive value side. So why was there such a high variability on the positive predictive value? Well, I've analyzed that here, but I've classified it on this slide. Essentially, you can divide this into patients, imaging imagers, urologists, and pathologists. So patients, their prevalence, for example, their preparation, the imaging that we do, the interpretation of the images, the biopsy skills of urologists, and of course the examination skills of the pathologists also. So if we look at this data again and look at the negative predictive value, in this particular analysis it's 96%, what are the factors that would affect the negative predictive value? Now clearly the patient is important, and we know that the negative predictive value correlates inversely with prevalence. So if you have a lower prevalence, you have a higher negative predictive value, and so that's the patient factor. The imaging and the images are obviously important, in other words, the interpretation skills of the radiologists. Remember, the urologists are only performing a systematic biopsy. There's no targeting involved, so there is less skill involved. On the positive side, there are many more factors that affect variability. We know that the positive predictive value correlates positively with disease prevalence. So the higher the prevalence, the higher the positive predictive value. Image quality is obviously important, as is reader skills. But because we've now got urologists targeting the biopsies, there is more variability there because of learning curves and the sizes of the lesions they are going for. So very many more factors affect the positive predictive value side than the negative predictive value side. So let's expand on that a little bit more. If you took PI-RADS 3, 4 and 5 to be positive scans, this would be your variability. However, if you took PI-RADS 4 and 5 to be positive scans, then your variability would be less. Similarly, you have to look within the PI-RADS grouping. If you have a larger lesion, PI-RADS 5, your variability will be less because the targeting errors are less impactful. However, if you have small lesions, PI-RADS 4 lesions, then the skill level is higher, and therefore the variability is also higher. So how do we minimize these variations of the imaging, the images, the pathologists and the urologists, and how do we quality assure the whole process? Well, one way of doing that is through automation. Automation in acquisition, automation in cancer detection, automation in delineation of the target lesions and of the gland outlining. And here is some data that's recently been published looking at an AI system for detecting lesions. And what you notice is that a radiologist with an AI has an increased performance. But what you also notice is that the inter-reader concordance is also improved. In other words, we are reducing variability. Other ways of improving variations in the imaging and the imagers is to quality check all the images that are produced. So when we look at the images, are they good enough to rule in and rule out clinically significant cancers? And we should state that in our reports. Clearly, education and training of radiologists is important, but their performance also needs to be monitored, and this can be done within multidisciplinary teams by getting feedback. Now, these are the quality criteria that were recently released by the Europeans, and I've left a reference there for you to look at in more detail. Now, multidisciplinary teams are absolutely essential for assuring the quality process. Multidisciplinary teams reduce variations in diagnosis and treatments. We know that it improves the effectiveness of referral pathways. We know that it improves the confidence of patients and their payers, and of course it's going to be integral to the accreditation process. So what's the difference between certification and accreditation? Certification is about the person, so the radiologists, the urologists and the pathologists. Accreditation is about the service, in other words the MDT or the diagnostic center. When you accredit a center, remember there's a number of processes that the center needs to get right. So in other words, accreditation looks at the effectiveness of the team working within centers. So what are the measures that you need to take to assure the quality of the diagnostic pathway? Well, there are 5 things we need to pay attention to. Number 1, we need to identify and measure the sources of variability. Number 2, we need to assess the impact of the variability on the outputs. We need to control these sources of variability through automation and standardization as far as we can. we need to monitor and maintain a high performance of all those people who are participating through education and training and team working. And we need to assure the end-to-end quality of the diagnostic chain by measuring key performance indices. So key performance indices would be things like turnaround times, patient satisfaction rates, biopsy complication rates, but also diagnostic metrics such as the number of biopsies avoided, the biopsy yields, the variability in the PPV and the NPV according to the PI-RADS categories, taking into account obviously the disease prevalence where you work. So key messages are that quality of the pathway depends on multidisciplinary cooperation and working. Radiology, urology, pathology have to work together, and so there is an interdependency there. So this relies on infrastructure, communication and seamless workflow. Clearly, quality assurance and quality control procedures are important to ensure the consistency of the pathway delivery, and I think that certification of individuals and accreditation of centers will be needed to ensure that we get paid by our results. Thank you very much for listening. I hope you found these comments useful.